Hey everyone. So today we're going to get into something that's, often overlooked, but is actually incredibly important in neurology, cranial nerve 12, the hypoglossal nerve. Now, its main job seems pretty simple. It just moves the tongue. But a problem here, it can give us these amazingly precise clues about what's going on in the brainstem, the skull base, or even the neck. So let's get right into it. So, you might be asking yourself, what can a patient's tongue really tell us about the health of their brain? Well, as we're about to see, the answer is a whole lot. Just a simple instruction, stick out your tongue, can uncover some serious evidence. It literally turns a basic physical exam into this powerful piece of diagnostic detective work. So here's our game plan. First, we'll get the basic anatomy down. Then, we'll look at the super simple test you use to gather your clues. After that, and this is the big one, we'll figure out how to interpret those clues to tell the difference between upper and lower motor neuron lesions. Then we'll apply all that to solve a couple of clinical cases. And finally, we'll lock it all in with some key diagnostic rules you can take with you. All right, first things first, we have to build a solid foundation, right? So let's talk about the anatomy and the function of the hypoglossal nerve. Seriously, understanding its job and the path it takes through the body is step number one to becoming a pro at localizing where the problem is. So what's its core function? Well, the hypoglossal nerve is what we call a pure motor nerve. That means its whole deal is movement. It's not about sensation, it's all about action. It controls pretty much every muscle in the tongue, both the intrinsic ones that change the tongue's shape and the extrinsic ones that move it all around. There is one little exception, the palatoglossus muscle. That's handled by the vagus nerve. But for our purposes, think of CN12 as the tongue's master controller. Now, the physical path this nerve takes is absolutely critical because, a problem can pop up anywhere along this route. It starts way down in the medulla, which is part of the brainstem, comes out, passes through a little tunnel in the skull called the hypoglossal canal, and then travels all the way down through the neck to get to the tongue. Knowing this journey is the key to figuring out where things went wrong. Okay, so how do we actually test this nerve? This is where our investigation really begins, the evidence-gathering phase. And the best part? The test is incredibly simple to do. To test cranial nerve 12, you just ask the patient to stick their tongue straight out. That's it. In a healthy person, the tongue is going to pop right out in the middle, perfectly straight. But if there's a problem, oh, you'll see it. The tongue will deviate, it'll point off to one side, and trust me, the direction it points is the single most important clue we're going to get. But hold on, we're not just looking for which way it points. You also have to really look at the tongue itself for two other classic signs. The first is atrophy, which is just muscle wasting. One side of the tongue will look smaller, kind of shrunken. The second is fasciculations, which are these little involuntary twitches or ripples you can see under the surface. If you see either of these, they are screaming that you're dealing with the lower motor neuron lesion. We'll get into what that means right now. Okay. Now we're at the absolute core of this whole diagnostic puzzle. We have to learn how to interpret our clues to figure out if we're dealing with an upper motor neuron lesion, which is a problem in the brain itself, or a lower motor neuron lesion, which is a problem with the nerve after it leaves the brainstem. This distinction is everything. This table breaks it all down beautifully. First, let's look at tongue deviation. This is the golden rule. For an upper motor neuron, or UMN, lesion, the tongue points away from the problem. For a lower motor neuron, or LMN lesion, it points toward it. Next, remember those other clues, atrophy and fasciculations? They are only present with an LMN lesion. You won't see them with a UMN lesion. And finally, the causes are different. UMN lesions are usually things like cortical strokes, while LMN lesions can be anything from a stroke in the medulla to a tumor or direct trauma to the nerve. All right, we have the rules of the game. Now let's actually put them into practice. This is where we apply that knowledge to solve a few quick clinical cases and see if we can pinpoint exactly where the problem is. But before we jump into the cases, here are some really powerful clinical pearls. When you see a hypoglossal palsy, you have to check the other cranial nerves, because if they're also involved, you can get way more specific. For example, if the vagus nerve, cranial nerve 10, is also out, the problem is probably in the medulla or the carotid space. If the accessory nerve, number 11, is involved, you should think about the jugular foramen. And if cranial nerve 12 is all by itself, the lesion might be right where it exits the skull, at the hypoglossal canal. Okay, case file number 1. You have a patient. You ask them to stick out their tongue, and it clearly points over to the left. You take a closer look, and yup, the left side of their tongue looks smaller. You see that atrophy. And you can see those little twitches, the fasciculations. So let's solve it.
The tongue is pointing toward the side that has the atrophy and fasciculations. That is the classic textbook presentation of a left-sided lower motor neuron hypoglossal palsy. The tongue licks its wounds, pointing toward the lesion. And given the anatomy we talked about, a small stroke in the left side of the medulla is a really likely cause here.
Now for case file number 2. This one's a little different. This patient has weakness on the entire right side of their body. When you ask them to stick out their tongue, it deviates sharply over to the left. You look closely, but there's no atrophy, no fasciculations. Okay, let's piece this one together. The body weakness is on the right, but the tongue is going to the left. See that? It's pointing away from the side of the brain that has the problem. That is the hallmark sign of an upper motor neuron lesion. So the conclusion here is a right UMN lesion, most likely from a cortical stroke that's affecting the right hemisphere of the brain. We've covered a ton of ground, so let's boil it all down into a final set of key diagnostic rules. You can think of this as your quick reference guide, your detective's handbook for the hypoglossal nerve. Okay, these are the absolute must-know take-home points. If the tongue points toward the damaged side, it is an LMN lesion. If it points away from the damaged side of the brain, it's a UMN lesion. Simple as that. And if you see atrophy or fasciculations, that just confirms it's LMN. And finally, here's a huge clinical pearl. Always, and I mean always, check the tongue in any patient who comes in with trouble speaking or swallowing. It's such a simple step, but it can reveal so much. And that's our deep dive into cranial nerve 12. It's just a perfect example of how one single, simple exam finding can help you unlock a really complex neurological puzzle. And it kind of leaves us with a final thought, doesn't it? What other huge diagnostic secrets are out there just hiding in plain sight? Thanks for watching.